welcome to Echo HBV workshop. This is our fourth and final module. Thank you all so much for joining us today and all of our other weeks. We're so excited to have Dr. Pan back as always, and we have a special guest, Dr. David Bernstein. Dr. Bernstein, why don't you introduce yourself to the group? Tell us where you practice and what you practice.
Hi guys. So I'm David Bernstein. I'm a hepatologist. For 16 years, I was the chief of hepatology and liver diseases for the Northwell Health System in New York. And now I'm a professor of medicine at NYU. And my role is to be in charge of the GI and liver outpatient network.
Thanks so much for joining us. Happy to have you join Dr. Pan for this session. And I know some folks will trickle in. As always, we always encourage you to turn your cameras on if you're able to. Understand, some of you are at clinic or at work, you're not able to, and you can always put questions in the chat and we will read those aloud. And I just wanted to get everyone thinking, since this is our fourth and final module, we would love to hear from you. Really want to hear your comments. And I think I asked this question at our very first module, what you hope to take away from this series. So that's what we asked at the beginning. So, as we're concluding, just think about what you've learned, what you can take back to your practice. I know a lot of you are in primary care, and what you've learned from our experts and from everyone else here in the Zooms. So you can always put that in the chat. And of course, we've got our evaluations at the end of each session. You can put comments in that as well. And just be on the lookout for a survey that will ask some of those same knowledge questions you've been answering for the past few weeks, and some confidence levels and practice change questions. All right, and Jill just put that in the chat as well. And just a reminder for some folks, I think everyone is pretty good. Well, no, we do have one Zoom user. So that's what your screen name is showing up at. So my colleague Jill will be reaching out to folks in the chat if we're just unable to identify you. We just want to make sure that everyone gets their credit for attending today. And of course, if you would like to claim CME or CE credit, you can do that by filling out the evaluation that we'll put the link to at the end of the session. So before Dr. Pan gets started on his presentation today, and again, we'll have questions and answers and then a final case, we do, of course, have a little pretest. So we will launch that. And again, we'll ask these questions again at the end. And we'll reveal the correct answer at the end of the session. So first question, how often do you screen your at-risk patients with chronic hepatitis B for co-infections? Would you say that you always do, often, sometimes, rarely, or never? And then you will need to scroll down to see the next question. Which hepatitis B treatment would be recommended for a patient with HIV and HBV co-infection? Pegylated interferon alpha, tobivudine, tenofovir disoproxil, or all of the above? We'll give everyone a few moments to answer those couple questions. So as people are answering, just want to welcome Gloria. Nice to have you back. Dr. Julius, Chris, Eduardo, Shantae, Dr. Samrat, Dr. Matt, Marissa, Shannon. All right, we'll just give everyone another moment. Okay, so we'll go into our fourth module.
So I will have Dr. David Bernstein to talk to you about the co-infection. David, when you're ready.
The topic today is really co-infections of hepatitis B with other viruses. If I could have the next slide, please. So here are our objectives, and they're really to identify patients for screening who have other viral infections. In particular, and the ones we're really most concerned about are HIV, hepatitis B, and hepatitis C, and they're really important. So if we sort of take the combination of hepatitis B and hepatitis C together, the reality is we don't know how many people have both infections that are active. We certainly know that there are similar risk factors for hepatitis B and hepatitis C. Not the sexual risk factors, so to speak, although you can get hepatitis C from any type of blood-to-blood contact, and there's an increased incidence in those men who have sex with men. But certainly through needle sticks or others, there's a risk of having hepatitis C on top of hepatitis B. Patients that have both infections are at a significantly higher risk of going on to progress to cirrhosis, decompensated disease, and then potentially developing liver cancer. Hepatitis B and hepatitis C are slightly different in the discussions regarding treatment. Everyone with hepatitis C who has any detectable virus should be treated because treatments are short-term, highly effective, well-tolerated, and readily available. But not everyone with hepatitis B actually requires treatment, and we do follow those guidelines. In someone who's found to have both infections right off the bat, you really should treat both. You don't need to treat one and then the other. It's important then to check everyone you're going to treat with hepatitis C for hepatitis B, because what we've learned is that hepatitis C seems to predominate when there are both infections. And when we treat patients for hepatitis C and their virus becomes undetectable, there's a significantly increased risk that those patients with hepatitis B will reactivate if they're not being treated and can develop active hepatitis, even liver failure. So if we were to take the different scenarios, if hepatitis C virus is present, treat. If hepatitis B is detectable in someone who also has hepatitis C, treat. If someone is being treated for hepatitis C and hepatitis B treatment is indicated, absolutely start treatment. If someone has hepatitis C and you're considering treatment, you should check for hepatitis B and see whether or not they have it, because if they do, you have to figure out then what to do next. What about then the management of hepatitis B during and after treatment for hepatitis C with a DAA therapy? So if we look what's to our left and follow this table down, we have a patient who has hepatitis C and who has overt, hepatitis B. What is overt hepatitis B? The surface antigen is positive and they have high levels of virus. Well, that patient you should start right away on both therapies. If their hepatitis C is positive, but they have low levels of HBV DNA that really don't meet the criteria for treatment for hepatitis B, you have a choice. What I would do is start the patient on hepatitis B therapy, and I would continue the patient on treatment after the HCV therapy is done for at least 12 weeks, probably 6 months afterwards, if not longer. And then I would check HBV DNA every 3 months after the patient has had an HCV sustained virologic response. If the patient at an outset, and if we take that same chart and go down, had cirrhosis, then you're going to treat both infections, no matter what the viral levels are, so long as they're detectable. In someone that has hepatitis C and very, very low levels of hepatitis B, something that we would call occult hepatitis B, you have a choice here. Here you can either observe the patient and follow HBV DNA levels every 3 months during therapy or after, or you can start the patient on therapy. Quite honestly, I tend to just start the patient on therapy for hepatitis B for the period of time that they're on treatment, because I find it to be safer and easier, and there really isn't a lot of downside to treatment. What about co-infection of hepatitis B and HIV? And here it's really a discussion of identification, because the risk factors are similar for both diseases. About 10% of people with HIV have chronic hepatitis B, and in parts of Southeast Asia, that's as high as 20%. Patients with HIV are at a much higher risk of developing chronic hepatitis B and its issues than those patients without HIV. So what about that co-infection? All patients with HIV should be receiving antiretroviral therapy with 2 drugs with activity against hepatitis B, tenofovir plus lamivudine or emtricitabine. When HIV therapies are being changed for whatever reason, drugs that are effective against hepatitis B should not be discontinued without substituting another drug that will work and be active against hepatitis B. Patients with HIV and hepatitis B, as well as those co-infected with HCV and Delta hepatitis, are at increased risk for developing liver cancer. So you need to screen these patients. And it's very important for all patients with HIV that you monitor the HBV DNA levels and adjust the antiretroviral therapy to ensure that you are adequately suppressing HBV DNA. And the real goal here is to make it undetectable. And so you can push the hepatitis B active component of the HIV therapies to maximize your ability to suppress the hepatitis B virus, since neither one of these viruses are curable, but both are suppressible, and with suppression, we can prevent progression. Next slide. The third virus that we're always concerned about is hepatitis Delta. And Delta is a virus that lives with hepatitis B. So for the 99% or so, you have to have hepatitis B to be able to then have Delta, and they go together. Patients who are co-infected with hepatitis B and hepatitis D are more likely to progress to cirrhosis at a more rapid pace. They are more likely to develop liver cancer at a rapid pace, and they are more likely to die of their liver disease than folks with just hepatitis B alone. That means it's critically important when you're seeing your patient with hepatitis B to check them for Delta. You should just check them once, unless they have active risk factors. But everyone who comes in should be checked for Delta, and you start out simply by sending the Delta antibody. Two different scenarios of Delta and hepatitis B. The first is you have both diseases together, so you get an acute condition, and you have both acute hepatitis B and hepatitis D. The second is you have hepatitis B, you're sort of going along, and then you get Delta. So you just need to be aware of that people can still get Delta after they've had hepatitis B for a while. What is the global burden of Delta hepatitis? I don't think we actually know that, but there's a lot more awareness now about Delta. So you can see here where there are some hotspots around the world for Delta. Russia, Mongolia, Greenland, and then you can see other areas like China, to some degree the United States, although I have to say in a non-Asian population and a non-Mediterranean population, it's really quite rare. We're just learning more and more about Delta. And I think that is we're becoming more aware because there are potentially newer treatments being developed for this. But once again, it's important that you identify Delta and check all of your hepatitis B patients for Delta, starting with the antibody. What is Delta? As I mentioned earlier, Delta requires hepatitis B surface antigen. Patients can get really sick, or they can just have chronic elevations of their enzymes. And just to reiterate, that the combination of hepatitis B and hepatitis D or Delta causes patients to rapidly progress to cirrhosis, decompensation, and liver cancer. So you really want to identify these patients. How do we screen? The Asia Pacific Society for Liver Disease and the European Association for Liver Disease recommends reflex testing of all hepatitis B surface antigen positive patients. That's what I do in my practice. The ASLD recommends risk-based screening, and I think we all should take a lesson regarding the word risk-based screening. Doesn't work for hepatitis C, and it doesn't work for HIV. So it's just better, and we've moved away from risk-based screening in both of those viruses. But the ASLD still has these categories. I would recommend to people, my opinion, that you follow the APOSL and the EASL recommendations. It's just far easier to check everyone who's got a hepatitis B surface antigen that's positive with Delta once. It becomes very difficult to sometimes figure out what the risks are for these two diseases. So that would be my recommendation. If someone you're looking for Delta, you check the antibody. That means, again, if you have an antibody, they either have the disease or they were exposed. So you have to follow up with viral load testing, and here it's HDV RNA, which is now commercially available. So that's what needs to be done. In the United States and really around the world, we still don't know the prevalence of Delta. It seems to be overestimated in a lot of areas and perhaps underestimated in others. And so by looking for it, we'll also not only be able to identify patients, but be able to better understand the risks in our communities for Delta hepatitis. How do we treat Delta? Well, we use pegylated interferon, like we can use for hepatitis B, like we used to use for hepatitis C. Delta, pegylated interferon, has been around for almost 30 years. The treatment of Delta is for 48 weeks, so a year. And at the end of that 48 weeks, response rates are between 17 and approximately 40%. But sustained virologic response is uncommon, so cure is uncommon. If you go longer with the interferon, you really don't gain anything. And because of this, many people, or in fact, most people with Delta hepatitis don't undergo any treatments. There's another type of interferon, lambda. It tends to be better tolerated, but the results are not dissimilar, and that's not yet approved. And then there are 3 other classes of medications that are actively undergoing investigation, although not approved yet in the United States. Some are available in a compassionate use, the viral entry inhibitors, bulevirtide, prenylation inhibitors, lonafermide, and then a virion egress inhibitor, REP2139. So I would look to the future for these medications to be available, probably the viral entry inhibitors before the others. I think that next one is the last slide. So this is the bulevirtide. This is a subcutaneous injection given every day for life. And what you can see here are the response rates. And so the combination of interferon and bulevirtide gets you about 90% of patients having a 2-log drop, about 30 to 40%, 20 to 40% will have an ALT normalization. If you look, however, at the combined response all the way to the right, which is ALT normalization and decrease in HDV RNA, really the best result is with 10 milligrams of bulevirtide therapy alone, so monotherapy. This is not yet approved in the United States. I know the folks who are doing the studies are trying to get it approved in the United States. It is possible at times to get this for compassionate use in certain patients with the manufacturer, but it's not approved.
And I think, Rachel, do we have any cases coming from the audience, or we'll move on the hypothetical case or the real case from China?
We've got our case from China. No patient cases from the audience. We do have some time for the question and answer, though, Dr. Pan, before we move on to the case.
Well, let's ask the audiences and see if any comments or any need for the clarification.
Dr. Moy actually asked in the chat, how is HDV transmitted?
How is which one?
Hepatitis D.
So Delta is transmitted in a similar way as hepatitis B, but a greater incidence with needle stick.
I think Dr. Bernstein mentioned that they could be either simultaneously, the mode of transmission, they're similar, they're blood-borne disease, but could be simultaneously, we call it co-infection, or you got Hep B first, because Delta rely on surface antigen to replicate. So you got the Hep B first, then later on, secondary you're infected with Delta, we call that the superinfection. And it's a little bit different in clinical presentation, but the results, they're the same. You have a coexist two viruses in the body. It's a blood-borne disease.
Yeah, and I think the key here is that you have to have Delta. I'm sorry, you have to have hepatitis B in order to get Delta. Yes, there are cases post-transplant in an immunosuppressed patient where there's Delta alone, but in a non-transplant patient, you don't get Delta unless you have hepatitis B, which is why vaccination against hepatitis B will also prevent Delta.
Thanks, Dr. Moy. Yeah, and if anyone else has questions, feel free. You can come off mute and ask the question, or you can put it in the chat. I just had a question that I put in the chat. I'll read aloud for Dr. Bernstein, Dr. Pan. Are people with HIV or HCV more likely to develop chronic hepatitis B if they become acutely infected?
So the answer to that is no. You know, if an HIV patient, however, is not treated, and is there by nature, is immunosuppressed, they are more likely to develop chronic disease and not clear. But if they're under treatment, it's the same. Hepatitis C, irrespective of their hepatitis C viral load or their disease, if they get hepatitis B, they're equally likely as someone who doesn't have to clear and not develop chronic disease.
Yeah, I would agree. And I'm not aware of any great evidence suggests that if HIV or HCV infected people would have more susceptible to a Hep B virus infection. But we also understand that if a patient is immunocompromised, like HIV patients, if you want to vaccinate them with hepatitis B, it's a more likely that they couldn't get appropriate level of hepatitis B antibody. So in that sense, would it be more susceptible for infection? That is not proven anyway. Because most adults, if they have been exposed to hepatitis B virus, their chance to get chronic infection is still small, about 5 to 10% max.
Thanks, Dr. Pan. And before we get to Dr. Moy's second question, and Julia said a question, I put one in the chat too. How are people with Delta treated? Are they given interferon and then after 48 weeks put on a nucleoside for continuing treatment of hepatitis B?
So if someone is identified as needing treatment for both B and Delta, they're started on their hepatitis B treatment, and then they're started on the current treatment, which is interferon. If they can last and take the 48 weeks of interferon for Delta, they tend to stop, but they continue the hepatitis B treatment for life. I think the key point here is that you're treating both diseases at the same time from the outset. It's far more effective to suppress hepatitis B than it is Delta, and Delta at the end of a year of interferon tends to relapse. It's also unfortunate because many of these patients they get sort of fatigued from the interferon. It's tough to take an injection with its side effects for a year. And so the key is to just treat the two of them at the same time.
Got it. Thanks. Dr. Moy's second question, in patients who have cirrhosis from hepatitis B, is treatment of any use, say in slowing down the progress or even reversal of the pathology?
I can answer that. For any cirrhotic patients, you definitely need to provide antiviral treatment, regardless the viremia level. Even they have undetectable level of HBV DNA. And any antiviral therapy have been studied in terms of reverse of cirrhosis nodules and histological findings. They got improved, but not 1 day, 1 month, 1 year. They usually require 3 to 5 year treatment minimum to revise the cirrhotic stage. So what we learned from the data is that if you have a patient, even they have luckily achieved a clinical cure. Last couple of modules, we explain the concept of clinical cure, the surface antigen come negative or even achieve seroconversion. For cirrhotic patient, even you get to that point, it's not a good idea to stop the therapy in short period of time because some of them actually can reverse or still progress without the antiviral therapy.
Yeah, I mean, I think I agree with Dr. Pan. I mean, one of the really interesting things is that when we went to medical school, we were taught that cirrhosis is an irreversible process. And now we know from hepatitis B studies that long-term use of the oral agents actually can lead to significant regression of fibrosis, which has led to a decrease number of patients on therapy developing decompensated disease and needing a transplant. So cirrhosis is reversible if you take away the stimuli. And so it's critically important that we treat all of our cirrhotic B patients if they have any detectable virus, pretty much for life.
Thank you both. Dr. Julius asked a question in the chat. If a pregnant maternal mother in her second trimester, correct me if I'm wrong, Dr. Julius, second trimester has a confirmed fetal gene deformities, more especially for leukemia, still qualify for stem cell harvest?
We need some clarification.
Yes.
Yeah, Dr. Julius, you can put it in the chat, or if you're able to unmute yourself. Said yes, has hepatitis B.
Okay, I try to answer that. I know you have a very complicated scenario. You have an immunosuppressive therapy going on, right? Possible. And also you got a pregnant mother. So I think it's a twofold clinical management dilemma here. Number one is you need to prevent the mother-to-child transmission, which, in module 1, we understand that if the infant get exposed to hepatitis B, chances are 90% without intervention, they can get chronic hepatitis B. So for the prevention of mother-to-child transmission, you need to monitor the viral load during the second trimester. If any viremia level above 200,000 IU, it's recommended you do antiviral prophylaxis on top of the infant HVB or vaccine that called post-delivery immunoprophylaxis. On top of that, you do need to provide a maternal antiviral prophylaxis to reduce the failure of immunoprophylaxis for the infant. So that's for number one. For the prevention, you need to monitor the viral load. Now, why we focus on the monitoring? We just finished a study in China and looked at several hundreds of mothers, even their viremia level less than 200,000 IU, about 8% of them gradually increase from the second trimester to the third and become eligible for immunoprophylaxis. The antiviral prophylaxis. So monitoring is a key. Any time point when they have a high level of viremia, you put the mother on just for the infant. Now, the second one is calling the prevention of hepatitis B activation. So for patients have been virological quiescent, undetectable HVB DNA, the chances we call reactivation is probably small unless you have a big gun, a high-level immunosuppressive therapy. But if patients have active viremia, chances are you do need to give antiviral treatment, not even getting to the point that we talk about the treatment indication for hepatitis B, but just prevent the reactivation or activation or worsening of hepatitis B. You need to put that on. So I do want you to look into those two aspects and see if you need to put the patient on antiviral. Maybe Dr. David Bernstein had different approach. We'd love to hear from him.
No, I agree with you. So I don't have much to add to that. So, I mean, you've done so much work in this area that looks
You both, as a follow-up to that question, would you recommend we harvest stem cells from maternal mother for neonatal futuristic cancer? And Dr. Julia said thank you to both of
yeah.
you.
You know, I have to apologize that this isn't something that I know a lot about.
I'll try my best to answer it.
Yeah.
I think it's really depends on the need for the infant in the future. You can always consult with physicians specialized in genetic disease.
Thanks, Dr. Pan. Any other questions from the group? And again, this is our fourth and final module, so your last chance to ask anything you like about hepatitis B. And I know some folks joined a little bit late after our presentation, kind of as we were going through the Q&A. So welcome, happy to have you here for our fourth module. All right, if not, we will move on to our case.
Before we go for the case, can I just ask Dr. Bernstein his experience on the co-infection for HIV and HBV? What would you do in a case that patient have been doing well in tenofovir-based treatment for HIV, HBV? There is a new treatment. It's a TAF-based, tenofovir alafenamide base. What is your experience? Do you have to switch them when you worry about a side effect, or it's pretty much just stay the same?
So, you know, what Dr. Pan is sort of alluding to is that there's some information out there that long-term TDF can lead to issues related to kidneys and bone. And would switching to TAF, which doesn't have that, potentially be beneficial for the patients with co-infection? You know, I don't know that we have the data, so to speak. It's very interesting because we have hepatitis B data long-term that shows TDF may lead to worsening creatinine and bone disease, but we actually don't have it in an HIV population. So in our co-management of the HIV, HBV patients with the infectious disease folks, we and those HIV patients that are on a TDF-based regimen and they're doing well, we don't change anything. We just watch them right now. So I don't know if you do differently, but we used to follow a large number of these patients and we just kept them as they are.
Yeah, that's wonderful. I understand that some of the audiences are actually from outside of country, outside of United States, from the developing country. I think you might still see co-infected HIV, HBV patients using lamivudine, but of course, data strongly suggests that anthracycline in combination of TDF or in combination of TAF, Dr. David Bernstein just mentioned, it's much better than lamivudine-based treatment. So bottom line, I think I want to reiterate the message of if you want to treat the co-infection patient, should not use one antiviral drug, should have a combination, and one of them must have the effect against hepatitis B virus, like Dr. Bernstein mentioned. So more common, we use TDF or TAF base. There is a single pill regimen, anthracycline plus TDF or anthracycline plus TAF. You can use that for more convenience for your patients if they have co-infection. Do not just use one drug. Can we move to the case?
Sounds good.
Yep, we can move to the case. All
Okay.
right.
I'm going to read the case to you. This is hepatitis B case. Patient is 40-something, right? 40-something male, born in Asia. Patient is surface antigen positive and have been there for when he was 2 years old. So it's a most likely early infection, possible vertical transmitted. So he took entecavir and antiviral treatment about a year ago. And because patient have viral load and also elevation of ALT, the liver biopsy actually show NASH and fibrosis at stage 2. So this patient have hepatitis B and the presence of NASH, stands for non-alcoholic steatosis hepatitis. He had been diagnosed with fatty liver disease in 2019. Have been there for about 3 or 4 years. Then PEG interferon add to entecavir treatment. It's an add-on treatment in April 2021. Only used for 6 months, a combination treatment, and he achieved a seroconversion of S antigen about 20 weeks after. Actually, he stopped all treatments at the end of the year after the combination treatment. So during the interferon treatment, he lost about 20 pounds, 22 pounds to be exact, and he recovered from the overweight, and now it's back to normal. So how would you monitor him? He had stage 2 fibrosis. It could be from NASH or could be from hepatitis B. How would you monitor?
Any thoughts from the group before Dr. Bernstein gives his thoughts? And you could always put it in the chat.
I think this is a very common issue. In the area have hepatitis B, high prevalence hepatitis B like Asia, particularly Southeast Asia. The ballpark number for coexisting NAFLD is about 25 to 30%. I think if you look at people in the area more well-developed, probably have an even higher incidence of fatty liver coexist with hepatitis B. And some studies have shown that fatty liver disease actually with Hep B have even worse outcome because you have cardiac risk and you probably double or triple the cancer risk. Hepatitis B causes liver cancer, but NASH also causes cancer too. So it's a huge concern. And now because the interferon side effect, it actually lost weight and probably reverse some of the NASH or NAFLD effect. But during the monitoring, what would you do? How could you confirm his current state of NASH or hepatitis B?
I think this case, as you say, illustrates a lot of different points.
Right.
First, it's from a U.S. standpoint, it's somewhat unique that, and we don't have more information, that someone who was on entecavir was then had pegylated interferon added to it. And it's also not common for patients to have us lose surface antigen and develop surface antibody, right? Which would be the definition of a surface antigen seroconversion. But it happened. Usually what we recommend in a patient that has a surface antigen seroconversion is continue the therapy for about another year and then stop. This person stopped, sooner than that. And the person had moderate fibrosis to begin with, really not advanced fibrosis. So I think you have to monitor a couple of things about this patient. The first is you have to monitor their hepatitis B for recurrence, because we do know in certain populations, patients that have a surface antigen seroconversion can have a recurrence of disease, right? And so I would follow these patients for the first year, at least every 3 months, with a full set of hepatitis B serologies, including an HVB DNA. The real question then becomes, since we know all patients with hepatitis B are at risk for developing hepatocellular carcinoma, how would you follow this? And patients with NASH are also at increased risk, although we don't screen regularly patients with NASH who have for cancer that don't have at least stage 3 or cirrhosis, which would be stage 4. I would probably, for the first year at least, get an ultrasound, every 6 months. We don't have here that what his BMI is, right? We don't know if he's lean NASH or he truly is overweight. But I think to sort of answer the 3 questions, I would follow hepatitis B serologies every 3 months for about a year. If he remains without a recurrence, probably decrease that to every 6 months and then annually. For NASH, there really isn't much to do other than see him, talk about diet, exercise, encourage weight loss. And then for fibrosis, your choices are depending on what's available to you to do something like transient elastography or repeat his biopsy and see where he now stands. Because if he doesn't have significant fibrosis and the hepatitis B HVB DNA is negative, I wouldn't regularly screen him for hepatocellular carcinoma. I think it's a complex case and there is no exact answer on what you do. Here's where medicine becomes more of an art than a science. And so it's going to depend upon the patient, the physician, and really the availability of these tests in whatever communities the patients are being seen.
Yeah, I totally agree with you, David. I think the most interesting thing in this case is, number one, Hep B looks like clinical cured or functional cured, but the NASH is still a puzzle. Like David mentioned before, what's its BMI and what is the baseline body weight? Because a 10 kilogram, 22 pounds, it really depends if he is a 250 pounder or he is like a 150. Usually, when patient lost 10% of their body weight, that their NASH probably got improved. But what if this patient is 250 pounds to begin with? So he 10 kilogram, not even reach the 10%. I probably very curious and see what's his NASH business going on now after lost about 10 kilogram. So given his doing better, losing weight, I probably wouldn't push him for liver biopsy, but definitely try to get assessment non-invasive testing and see number one is his fibrosis can get better, or his more importantly, his fat accumulation in the liver, which you can use a fiber scan, use a CAP score to define. Usually severe fatty liver would be more than 290, the score. Significant fat, you can see that as 230, 38 or 240. In between it's 260. So you can read on the CAP score and see what's going on with his fatty liver. Of course, we won't be able to see the information unless you do liver biopsy. But let's say if the CAP score come back very low and he lost those weights, actually can reverse the fatty liver condition, then the monitoring probably is less frequent. Well, versus he have like S3, significant fatty liver disease, then I do need to worry about his stage 2 fibrosis progress, not by hepatitis B, but perhaps from NASH. And that may tip me off in terms of decision a year later, status of a year or two, when he hit age 40. If a stage 3 fibrosis, I would probably routinely screen his liver cancer. So it's a tricky question because we don't get a lot of baseline information. But in terms of why we add on interferon, most recent data actually show that a patient on antiviral therapy for 2 to 3 years and HBV undetectable plus the surface antigen less than 1,500 titers. When you add on interferon or switch to, you have about 30% chance to get clinical cure. So I think that might be the case. So at that time, even though we did not have the surface antigen titer, but presumably he had met that criteria, so can easily to get the seroconversion. Another question is, I want to run this by David. Would you offer vaccine for this patient, hepatitis B vaccine, if the seroconversion is reversed? I mean, reverse the negative, not getting the antibody yet.
So that's a great question. So the scenario is you lose surface antigen, but you don't develop surface antibody.
Right.
I actually would offer this patient then vaccination.
Right. It doesn't.
I don't know that that's the right thing to do, but it just seems to make sense. And I've done that for a bunch of patients, and I have to say half of them develop antibody and half don't. But my presumption is that they develop the antibody, then they should be okay, provided their HBV DNA is undetectable. But I would offer it. Calvin, what about you?
Yeah, absolutely. In 2018, I worked with the Chinese investigator. We have more than 400 patients after interferon treatment. And we look into two things, those have surface antibody. It doesn't matter you got vaccine or automatic converted surface antibody, versus those without. The antibody would provide the benefit of more sustained viral suppression or less flare. So I think giving there is no downside of giving vaccination, I would go the same approach that you just proposed. Now let's twist this case a little bit. What if the patient wouldn't have NASH but HIV? You have a surface antigen positive patient have been on entecavir treatment for about a year, and now you find that the patient have HIV positive. Let's say he had a history of MSM lately and got infected with HIV. What would you approach? What is your approach in terms of treatment? I want to hear from the group. Do you continue entecavir or you need to switch therapy? Any taker? Now you have dual infection. We're not going to touch Delta because there's not that much you can do. You give a shot and you can achieve clinical cure. That's good. Other than that, you have to put antiviral forever for Delta. But HIV, what we should do in an HIV patient, just new diagnosis, but taking entecavir. Would it be good enough using entecavir? Let's say his CD4 count is 600. Still have a decent CD4 and have no complications from HIV.
Dr. Moy in the chat said I would continue entecavir and treat HIV as well.
Yeah, that's one option. If you add on the cocktail, any hard therapy on top of entecavir, that's acceptable. But what's the downside of taking multiple medication? Maybe your patient compliance is the issue. Would any therapy replace entecavir, but part of the HIV regimen, so you don't have to keep entecavir?
I think someone answered that in the chat.
Could you read that out, Rachel?
Sure. We can convert the regimen to TDF, emtricitabine, or lamivudine, DTG.
Yeah.
3TZ is the old regimen.
Preferably the TDF emtricitabine regimen. Because remember, with lamivudine, there's a high rate of resistance in hepatitis B. So you really want to, if you're treating hepatitis B, avoid lamivudine. It was great when we did the first studies way back in the 90s. And I remember it being a miracle because we did them at the University of Miami. But it's a medication that is still used because of cost, but there's really a risk of developing resistance. So if I were treating the patient that Dr. Pan just presented, I would stop the entecavir and I would add I would put the patient on a TDF tricytidine type regimen, because you want to have 2 drugs that will cover the HIV, and then you'll get your hepatitis B as well, or more. And the more medications they take, the more likely they are to not take them all the time. And so for compliance issue, I think it's very helpful to use the regimen that was just mentioned.
Yeah, absolutely. I think the best choice would be the TDF-based HIV regimen or TAF-based.
Right.
The 2-in-1 is, the Truvada is the TDF and plus anthracycline. If TAF is called Descovir, it's a single pill regimen, much more convenient. And both medication would cover, it's like nucleoside plus nucleotide, cover both hepatitis B and HIV. So I think that might be a most convenient and high efficacy. I guess we can go on the post-test, right?
I think we
Yep.
will. Yeah, great discussion. Thank you, everyone, really so much for your comments. We always appreciate that and love having Dr. Bernstein available to join us today to have a great discussion with Dr. Pan. Okay, so let's go to our post-test. It's our final post-test. And you will see these questions pop up. So this is post, so just keep that in mind. As a result of this activity, how confident are you now in treating patients with co-infections? Would you say that you're much more confident, moderately confident, somewhat more confident, or not more confident? And then question 2, which hepatitis B treatment would be recommended for a patient with HIV-HBV co-infection? Pegylated interferon alpha, tilbivudine, tenofovir disoproxil, or all of the above? Give everyone a moment to answer that. And as you're doing that, Jill is going to put a link to the evaluation in the chat. Again, as always, just make sure that you are logged in using your DKBmed account. We do encourage you to use the Chrome browser. It seems like that works best for folks. And answer all the questions. Click the green submit button. You'll also get all of this in an email, so you don't have to remember all of that right now, but it's in the chat now for your convenience. And again, look for our survey, which will ask you some questions about the last 4 modules, last 4 weeks. It's really been a pleasure meeting all of you. We hope you've enjoyed the ECHO format. We have more ECHO programs coming, and hopefully on hepatitis B, but also other disease states as well. We've got some new ECHO migraine programs starting later this summer, and actually tomorrow if you're interested. And again, any questions, feel free to email. Jill will put it in the chat, our email address. I just want to give everyone another moment, but we're at 1 o'clock. So we'll end the poll, and yeah, our questions, it's echo@dkbmed.com. So let's see our results. So it looks like we're more confident, which is wonderful. And I know we just talked about this, so hopefully with more education, we'll be even more confident. So we're a little mixed here. What's the correct answer here, Dr. Pan?
Well, I think we just mentioned either tenofovir DF base or TAF base. It's tenofovir base. So many of you actually picked the right answer, almost 67% correct. So we are very happy. It's a tough question. You don't see those patients quite often, but I'm glad that most of you picked the right answer. Thank you.
Okay, thank you. And again, as I mentioned at the very beginning of this, as I know some of you have to run, but if you would please leave some comments in the chat or just do it, you can email us or put it in the evaluation. We'd love to hear what you can really take away from this series and bring to your practice. I know a lot of you work in primary care, so it's been great to hear from experts the last few weeks. All right. Well, thank you so much, everyone. Last ECHO clap, and we hope to see you soon for another ECHO very soon. Have a great rest of your Tuesday.
Thank you
Thanks,
guys very much for
everyone.
inviting me.
Thank you. Thank
you,
you for
Dr.
joining
Bernstein.
us.
Have a
And
great,
thank you,
Take care.
Dr.
great rest of the
Pan.
day, wherever you guys are. Okay, bye.
Thank you, David.
Bye.
Bye-bye.
Thank you.
Thanks, Calvin. I appreciate it.